We're pleased to introduce September Wallingford, who is the operations director for Costs of Care. Ms. Wallingford also is a practicing medical surgical oncology nurse at a large academic medical center in Boston, Massachusetts, and brings significant interpersonal insights into the cost of care team. Dr. Reshma Gupta is a practicing internist, the chief population health and Chief of Population Health and Accountable Care at the University of California, Davis Health in Sacramento, California, and part of the Population Health Leadership Team for the strategy across all UC Health campuses. She works as a senior advisor with the Center for Medicare and Medicaid Innovation to test new models of value promoting payment reform. And Dr. Gupta also serves nationally as co-director of Costs of Care. And finally, we have Renee Ferrato, who is a young adult leukemia survivor, a current adult breast cancer patient, and a single supermom to 8-year-old Ava. She is also a preschool teacher, a writer, an artist, a warrior, and an advocate who is passionate about making the cancer experience better for all patients. So we're very excited to introduce everybody today, and I'll turn it over to you to talk about these important things.
Great. Thank you so much, Kelly. And that was a great introduction. And I also want to introduce Jennifer Lorenkovitz. She's a senior manager of programs at Family Reach, who's also joining us today to talk a little bit about her organization and the great things that they do. So thank you so much. And thank you to the ABIM Foundation for inviting us today and for pushing us all to think about how to make the health system more trustworthy and why we need to do that now. So we're here to talk about the Affordability Accelerator and focusing on patient out-of-pocket costs, which we believe is the next frontier in value improvement. Next slide. A little bit about Costs of Care. We're a healthcare nonprofit based out of Boston, Massachusetts, operating with the understanding that nearly everyone who receives healthcare in the United States is at risk of receiving care that is so expensive, so unaffordable that it threatens their financial security. And so at Costs of Care, we work to curate insights from people on the front lines of healthcare delivery, and that includes patients, so that clinicians and health systems can deliver more affordable healthcare. And in doing so, we're really working to build a pipeline of change agents focused on improving the affordability, equity, and trust of healthcare. Next slide. Our team is spread across the country. We're a group of passionate frontline clinicians, administrators, students, and all of us, like most of you, have been patients in the American healthcare system at some point in time, to varying degrees, of course, but we've all seen the healthcare system up close personally and professionally, and that really gives us our perspective and our passion to want to help fix it. Next slide, please. And we see the urgency in helping to fix the system. And in December 2019, our team launched the Affordability Moonshot, where we envision a world in which no one has to choose between their life and their life savings. And we know we can't do this alone. We need change agents, champions, leaders, and partners to engage in this work with us. Where improving the affordability of healthcare so vitally intersects with building trust. And an instrumental partner in this work is an organization called Family Reach. And I'll let Jennifer introduce you to her organization. Jennifer.
Thank you, September. And thank you for inviting me to talk on behalf of Family Reach today about the work that we do. We are really thrilled to be a part of this conversation. So Family Reach is a national 501c3 nonprofit organization dedicated to removing the financial barriers standing between a cancer patient and their treatment. Loss of income, out-of-pocket expenses, and the socioeconomic factors creating disparities in the financial burdens families face. So Family Reach delivers the Financial Treatment Program, also known as the FTP, which I'll share a little bit more later in the presentation, but the program includes financial education, financial coaching, resource navigation, and emergency relief funds to patients and caregivers facing a cancer diagnosis, so no family has to choose between their health and their home. So with that, I'd like to introduce you to a very special person to Family Reach. Her name is Renee Ferrato. And Renee, can you introduce yourself and share a little bit about your story?
Good afternoon, everybody. My name is Renee Ferrato, and as you've heard before, I'm an acute myeloid leukemia survivor, a bone marrow transplant recipient, a metastatic breast cancer thriver, a single mom, and a very grateful recipient of Family Reach's assistance, which has led me to become a very proud patient advocate. And I share because cancer is a very brutal and heartbreaking disease. And for some reason, everything worked for me. And I hope that sharing my story and the things that have worked and the things that have not worked helps provide hope to other patients and helps bridge these gaps in healthcare that we need to fix.
Great. Thank you so much, Renee. We're going to jump into the first section of our slides. So I'm going to be covering some background on our current healthcare affordability and trust crisis. And then in our second section, we're going to talk about an affordability framework and then touch on how we can really think about rebuilding trust having this background. Next slide. So I'm going to jump straight into the problem. So I wanted to share just some of the clips over the last year and a half that have come out really relevant, even more so during COVID and kind of our economic downturn. But the public is now hearing more and more about these prominent reports of overuse, unexplained price variability, excess profits, and also these surprise bills or cost shifting to patients. During COVID, here are just two examples, but we saw some labs actually charging greater than $2,000 to patients for a single SARS-CoV test. So it's front of mind and very apparent to patients throughout our communities. Next slide. And when we think about how trust and healthcare affordability intersect, I want to share a few key points. One, that public trust in leaders of the health profession, really assessed in aggregate, has substantially decreased, from almost the mid-century, and alongside a reduction of trust in institutions. So as a healthcare profession, as well as within institutions. When it comes to healthcare affordability and those surprise bills, these are things that really contribute to that reduction in trust. And part of it is when we think about the fundamental parts of what building trust means, a lack of transparency, getting surprised, being caught off guard, not having clear communication. A lot of these components go hand in hand with what's happening with surprise billing. And then the third key component I wanted to mention was that our health systems are sometimes not ready, not yet having the infrastructure and the training to partner with patients to kind of support them through this process. And some of those key components, like I mentioned, is that price transparency, that infrastructure that I mentioned, to really help identify patients who are at financial risk of potential harms. And then having communication about cost conversations. And to be honest, a culture of tradition, but in an environment where the communities that we work in and our patients are needing something different. Next slide. So when we look at statistics, nearly 30% of Americans delay care due to costs, and that's up from just 2004. This means effects of missed appointments, medications, workups, and that can be, from direct costs, which include hospitalizations or medications, but also indirect costs, such as the cost of parking, transportation, or childcare needed to make visits. Next slide. So there's a surveys that have been done, and it's actually been replicated a few times, but one from a New York Times poll actually asked, do you think your doctor should discuss the cost of recommended medical treatment with you ahead of time? And patients are saying almost 80% that they should, but in reality, when we've looked at studies, what's actually happened, only 15% of patients are reporting it's actually happening, and the physicians are reporting at 35%. So there's no doubt there's a huge gap here one way or another. Next slide. So at my local institution, we actually did a survey, and this was a small pilot, and then we've kind of done it at a larger scale. But when we were initially looking at this and asking patients, when you think about social influencers of health, for example, and we added cost to the traditional categories that we look at, what would come up on top? And there was no doubt that cost of care was a huge motivator, even locally. Next slide. Nationally, we also know that more than 50% of households are spending 30 cents to $1 on income in healthcare. And if you see this trend, even from just before 2000, the y-axis here is affordability index, which is really the mean cost for insurance over household income. And it is just going up in a stream. So I wanted to give a moment, just knowing this background, to actually pass the mic over to Renee to hear some of her reflections on some of these trends and what's going on with trust and affordability.
It's definitely shocking to see the graphs and see how quickly it's rising and doesn't look like it's coming down anytime soon. And it is incredibly frustrating knowing that you have healthcare issues that you need to take care of and things that you need to address. And at the same time, there is a huge barrier of filling the gap financially, whether it is, cost of medications or family life at home. I know myself, I've deterred health procedures simply because I don't have the financial means to cover myself after I have my procedures. So it's very frustrating.
Renee, can you tell us a little bit about how some of those costs affected you? I know that, around the time that you were planning to go to college, there were some discussions around this in your own story, and also the component around indirect costs too, and that complexity between the two.
Well, definitely the college fund that I had set up went completely to household expenses and the costs of getting back and forth to the hospital, because I was at a hospital in Palo Alto, which is further from where we lived. So that also meant that my mom was a single parent at the time. So that meant that she had to leave her job so that she can come and take care of me, because I was completely incapacitated at 18 years old. So that's how I started adulthood, was incapacitated and financially strapped because of an unforeseen health volcano that I have never recovered from. I never got the chance to go into college because I had to focus on my health for so long, especially after having a bone marrow transplant that meant complete isolation from the entire world. So it didn't just impact the medications and the hospital time, it permanently impacted my life and still does. Which is why I'm a patient advocate, because I'm still living in the thick of it and I'm still not getting any resolution. So I hope to make resolution.
Can you tell me a little bit more about that too, or with all the folks here on the call, about kind of what those experiences were for you, especially when you received some of those bills, and what the communication was with your care teams? I know you've had a number of different medical centers and doctors and physicians and things you've worked with, but kind of just to help us understand that a little bit better.
Well, just recently, and this is something that I had leukemia at 18 years old, and now I'm 37, and I've been dealing with metastatic breast cancer for the last 2 years. So I've had quite a fair share of radiation and chemotherapy throughout my life. But one thing that was constantly overlooked was my dental health. And dental health, as we all know, that your dental health is incredibly important to the rest of your health of your body. So just recently, I needed a crown on a root canal, finally got into the dentist, finally overcame the anxiety of having to remove my mask in a COVID environment to let somebody into my mouth to fix my mouth, to find out that it's a $3,000 bill out of pocket because my insurance doesn't cover it. And I haven't been working since 2019, since I was diagnosed. I have no, I have no option. I have a broken tooth in my mouth and dental coverage that won't cover it. So it's incredibly heartbreaking, because here I am trusting the respectful advice and opinion of my healthcare providers, and yet the coordinating schedulers are incredibly cold and flat out told me that if I don't schedule this now, the rates will change in the next month, and they cannot promise me the same quote. So you almost feel pressured for your healthcare.
Yeah, sounds like you were left without a lot of options to choose from. And it kind of sounds left without being empowered in that scenario.
Absolutely, absolutely. If you look at healthcare like a grocery store, we have all these options and all these different, things here. Why is this so unaffordable and unattainable when there's so much here?
Tell me a little bit too, when these kind of bills like you've described come your way, and I know you've had many along the way, which are the ones that you felt like really knocked you off your feet the most? What were the largest ones, or the ones that you were most unprepared for?
The prescription costs are a little out of control. I remember after I had my bone marrow transplant, one of the anti-rejection medications that I needed to take quite often was incredibly expensive. And it's frustrating because I can't take a generic, which then leads to the other problem that, my doctor has prescribed a medication to me. I'm trying to get it. It's too expensive, so I'm offered a generic form. Well, then that creates doubt in myself and thinking that this medication is not as strong, so that tethers on those trust bridges. So it's there's some things like ambulances, that's going to be a great bill, but it is definitely limiting when you see how much a prescription is going to cost, and you don't know how you're going to pay for it.
I want to ask you one more question, then I'll pass it over to Kelly to take some questions from the group. But how do you feel that your trust in the health system was affected by some of these experiences?
It's conflicting because, like I said, it's blind faith and trusting that my doctors and the healthcare professionals know what they're doing. And so I'm going to trust their word and take their advice. And then at the same time, somebody who's not a medical doctor is deciding whether or not they're going to cover this, or if I need the generic form, or if they're going to cover the actual form medication. And that's confusing to me. If you're in insurance, then you should have somewhat of a medical, experience here, and not just have the power to make the decision yes or no.
So I think we'll jump into the next section. So we'll go to the next slide. And we're going to touch on the affordability framework. One of the things that we've done is actually took a look at when we think about trust and affordability. One of the things our patients often told us is we need to go beyond lip service, and we really need to think about what can be done to get outcomes. What is really going to help us build that infrastructure to move the needle on reducing out-of-pocket costs. So we're going to share some of that with you today. Next slide. So we created a framework, and this is actually, we can send this link actually at the end, was published in NEJM Catalyst around a framework to address patient affordability. The 4 components include measuring affordability, having meaningful, actionable data transparency, where you can really use this data at the point of care when we're talking with patients, and then training and then shifting care to clinicians that are trained to do this work. And then also developing pathways to address affordability, especially for more underrepresented or vulnerable populations of patients. So we'll jump to the next slide, which is really hitting on that first one, which is how do we measure patient affordability? And this is something that we've spent actually a couple of years really trying to get our mind around. And, you know, from a data perspective, there's a lot of different ways to think about it. But if we move forward on the slide, you'll see a few of these ideas. One is out-of-pocket cost transparency. And this is an area that still needs a lot of work when it comes to measurement. But there are areas that have done this well around pharmaceutical costs, for example, where we can really see what out-of-patient costs are, sometimes at the point of care. And then there's ideas around responsiveness to financial concerns. What is the impact on those more vulnerable populations? And, you know, are we providing care at lower cost, at high quality providers or sites of care? These are things that are not currently part of reporting or programs that our medical centers and practices are being held to in terms of accountability. But these are things that when we think about not only that out-of-pocket costs, but that experience when those concerns come up, similar to what Renee mentioned, we need to think about, and some of these have come from our patient colleagues. Next slide. And Renee, I'm actually so glad you brought up that specific case that was really recent about dental care, because part of this is also knowing that when we talk about measuring what are out-of-pocket costs, cost to who often comes up. We have traditionally been trained from a management or medical center perspective to think about total cost of care. And what you see here from this data that actually comes from the Office of the Actuary and National Health Statistics Group, on the left here, it actually has a various number of costs that are expenditure and expenditure type. And we see the majority being hospital, physician, clinical services, pharmacy that we often think about from the health system. But what's so interesting is that we often haven't asked, what does that mean for the patient? And what we realize, it's a very different graph. And dental care, just to bring up Renee's point in the green there, is a huge part of that. Other parts are non-durable medical products like gloves and disposable Foleys and catheters, things like that. Durable medical equipment, which is often wheelchairs, things of that sort. Physician and clinical services, pharmaceuticals, all of these things come up quite high. And so the targets for intervention might actually be a little bit different. Next slide. Number 2 in the framework is look at meaningful, actionable data transparency. So this is one of the hardest, maybe highest hanging fruit for some institutions in terms of building infrastructure, but it's really having that cost at the point of care so we can help inform shared decision-making with patients. And we have 2 examples here that I'm going to share with you. One is the University of Utah, who actually created something called a price transparency tool. And they did this for the most common procedures in inpatient or outpatient. And what it does is a patient can actually input their health plan information, including deductible and copay, and actually provides an estimate of the out-of-pocket costs that they may receive for those. Another example actually comes from the payer perspective, but from Blue Cross North Carolina. And what they've done is they previously posted quality and cost information online for patients that are work within their system. And they've expanded partnerships to both health systems and with benefit design companies to use behavioral economics to address and help patients more at the point of care. So an example of this is when patients are selecting a high value service at a lower cost site of care, they're actually eligible to receive cash reimbursement for making those high value selections. And it engages patients both in what is beneficial for their own out-of-pocket costs, but also from the total cost of care perspective in really engaging patients in that shared decision-making. Next slide. The third point of the framework is really about training. and really thinking about how we're engaging our networks of clinicians and staff within our medical systems and practices to discuss costs, to be able to access data at that point of care, as we've mentioned, and try to incorporate this into individualizing care plans that's critical for this work. And when we think about what that means in terms of training around cost conversations, it's asking some key questions about, is the care necessary? If it is necessary, how to find the most affordable care, and helping to navigate patients in that way. And if care is both necessary and expensive, how do we pay for it in that scenario? And I think part of this sometimes involves additional infrastructure around financial navigation, but many of these things, when we look at what's out there in medical centers and practices, it seems like it's far away. And I think part of this work, especially from a health system or practice perspective, is that it's not necessarily for the lighthearted. It's going to take some work to build the infrastructure to do this in practice, and from learning from those that have done it before. Next slide. The fourth component of the framework is creating pathways to address affordability for underrepresented or underserved patients. So these are workflows that involve screening, potentially having focused committees to deal with those more complex situations, and individualizing care plans. One idea around committees is that if we have a patient where we know that the care is of high value and it's expensive, and it's part of the patient's goals of care, how do we bridge them to deal with that bill that might be coming down the road? And so similar example is actually tumor boards that we have in the medical centers for very complex cancer cases, bringing together specialists to sit down and talk through the case and really brainstorm what might be the best path forward. You can imagine something very similar, but this time with different partnerships, bringing in finance, bringing in billing, who can walk through with patient navigators, financial navigators, what are potential options that we can really bridge the needs of our patients. So as September had mentioned, we held an event not too long ago called the Affordability Accelerator, and actually pulled out some key ideas that came from this. It was a convening of almost 40 key partners around the country that are experts around affordability, but from all different perspectives, including patients, patient navigators, social workers, experts in the field around affordability and value. And some of the key things that came out we wanted to share with you around what are some of these examples that might be involved with these pathways. One is a couple ideas that came out were developing integrated clinical and financial pathways. So that includes things such as financial toxicity order sets that not only help us to remember to screen for patients around their financial component of their care, but also things that could be done to mitigate when that care is necessary. And some of those financial parts of that pathway include navigators potentially. Two examples here is Kaiser Permanente Southern California actually integrated a screening tool to identify community services to help specifically with financial planning and also social determinants or influencers of health. Health Leads, another national organization, has actually used these clinical financial pathways to get folks into community resources that target even more so on some of those indirect costs of care, including transportation, food, and other things that are related. Next slide. I also wanted to share some of the true barriers and facilitators that were identified through this event that we held. Some of the lessons learned. Barriers, there's a lot, but there's also a lot of facilitators that we're going to share with you. Lack of out-of-pocket cost transparency or plan-specific data at the point of care. Misaligned incentives sometimes between our health systems and lower cost sites of care. Training in cost conversations, having existing pathways to guide patients when care is expensive, essentially not having existing pathways, lack of funding from financial navigators or financial ramifications of unexpected care that's sometimes hard to predict. Much easier in the example I gave where we can kind of predict something a couple months in advance. A lack of partnership between care teams and finance teams, and partnership between medical centers and payers. Some of the key facilitators include that our patients are excited to partner with us. We know that, and this came up again and again in talking with patients, including Renee actually, is that there's an energy around the experiences that they've had, really getting deep into their care and walking through those experiences and wanting to join in that effort of co-creating plans. Financial resources and pathways are new. And so developing new ones around them can seem challenging, but patients who are the ones who, like I said, have really granular insights can help co-develop those programs. Another facilitator is new policies. There's more and more accountability that's going to be coming towards health systems and practices to really support transparency, to work between health systems and payers to mitigate bills. So there's less cost shifting to patients. To protect patients, and new tools are being developed to make workflows easier, similar to the pharmacy medication program that I mentioned earlier. There's also opportunities to learn from existing programs that use patient navigators for financial navigation. And more than anything, considering what our country's gone through in the last few years, what's been one of the biggest policy issues of our time in the last few years, affordability of healthcare is so vital. It's time for this work to happen. Next slide. So I'm going to hand it back to Renee to really ask her reflections on what you heard, and also, what you would have wanted to see in your care.
Well, I feel like a lot of the issue with affordability of care is the availability of it, and that we're stretching our means here because it's not available to everybody. I fortunately have been lucky in my series of unfortunate events because of where I live and the demographics of my lifestyle, and I have had success with those benefits. And it's heartbreaking to see that other people don't have that same access. And with healthcare, and like Rishma said, we absolutely want to get involved, because even when you are cancer-free, you're really not. It opens this whole door into healthcare and things that you never thought about. And you are inspired to help because you're involved in it. I would have never thought that I would have ever been 37 years old and having to wear a prosthetic and having to juggle the fact that I can't get a new one because I need to pay my rent, and I can't get a new lymphedema sleeve because they're too expensive, even though I have a prescription that I'm supposed to be wearing this on a regular basis. So it's very frustrating. So a call for action is definitely heard as far as patients are concerned, and we actively want to join the mission here, because it is a little out of control.
Renee, when you think about, let's say, your dental experience that you just shared, or one from the past, when it comes to the communication that either if it's someone that works in the practice, or it was directly the clinician, or whoever was on the phone with you, you could get a hold of, if you could get a hold of someone, can you talk to us a little bit about like what they could have done in communication that might have helped? And even with the bill there, what would have been helpful?
It was the approach. It was the language. It was the demeanor. It felt like I was literally asking this person to cover the bill for me so I can get this fixed. It felt like she, the person who was going over the financing for it, felt like it was her pocket. It was her money. It was her insurance company. And it was almost like she was offended with me by my shock and questioning of the price and questioning what my options were and questioning why I have to open a credit card to get my tooth fixed. You know, and she took it almost like she took it personal. She took my healthcare personally, but it's my healthcare. And that I also, like I said, I felt pressured and that I didn't have any other choice. I didn't have any other options. So to rewind that, it would have been much more comfortable to have somebody with a little bit more empathy and understanding that, you know, we'll work with you on this. There's not a, you know, time frame here. You know, you don't worry about the financing charges. Let's take care of your health. But the lack of empathy was the hardest part to deal along with the bill.
No, such a power. Yeah, I think so powerful to hear you explain it that way. Kelly, I'm going to hand it to you for any follow-up questions.
Yeah, again, I want to encourage people to put something in chat or unmute yourself and make a comment or question. But one thing I'd love to hear from all of you is, you know, Renee, I think your experience with having people who are typically trained as gatekeepers not being compassionate is not yours alone. So I think this is like Renee's voice is a voice that many healthcare organizations need to hear. Do you have any practical advice for engaging patients in cost work in an organization, especially when it is a rather slow process? And that could be for any of you, September, Reshma, Renee.
I think people forget that we're human. I get it. It's an industry. We're all here to buy things. But like I said earlier, with the grocery store, you have lots of options. You have the option of refusing to purchase something that's too expensive, even though it's probably good for your health. But having a clear idea of what the variation is for all these different kinds of apples, depending on their grade, knowing that they're all going to work for you the same way, but giving that consumer the control to consume, that I think is the mission here. And I think that the more that we have patient involvement in healthcare, rebuilds the empowerment from the shock of getting a bill that is unbelievable. But having a patient that is able to sit there, that's a financial advisor as well, saying, I've been in your shoes, this is what we do, it's what I've been trained for, and this is my personal experience as well, and let's go through this together.
Yeah, I would.
Reasonable humans.
Yeah, all I have to say is kind of echoing, I mean, Renee's words here, but there's a component that come and from multiple prior conversations I've had with Renee and other patients we've talked to, but there's a component about compassion and empathy, right? And just understanding I'm a person with a story. There's a story behind this. I'm just trying to do my best. But then there's also another piece about not just the lip service that I mentioned before. And, you know, thinking about that reaction on the other side, to me, it sounds like that person on the phone was caught off guard. They didn't have the training, they didn't have an infrastructure, overwhelmed and not sure what to do, even if they wanted to help. And so they're kind of reacting in the moment unprepared. That doesn't always come off perfectly. And so it's kind of thinking about that from that health system or practice perspective of really needing like a vision around this is a real issue that needs a real strategy. So staff know what to do. They know what to say. They've said it before and they're not afraid to ask those questions.
We do have a comment in the chat from Bill Adams. We need careful and kind care, to quote visitor Montori. That includes from all we encounter in healthcare systems, caring for this patient, not patients like this.
Yeah, and I'd like to mention too, I'd love to challenge everybody to think about their own personal barriers to not inviting patients into this work. Wherever you sit in the healthcare system, thinking about what you can do to break that barrier personally and professionally to get more patients to be a part of this work, to hear their voice. I think sometimes we worry that the patients will see behind the curtain, but we forget that they've already been behind the curtain and it's not great what they've seen. And so this is a way to really engage them, really get their perspective, really understand where the financial friction points, and how to use their knowledge and expertise and experiences to improve your processes.
Great. And we do have a question in the chat that says, do you have any suggestions for how to build a business case for financial navigators?
I'll jump on this one. There is no doubt that we are in a space that is very early in this field for transforming care. We're at such an early phase that we don't have all the financial incentives like we do for quality programs that the government and state ask the medical centers to report to. We're not asked to report about this except for that new legislation around surprise billing that just happened right in the last 6 to 8 months in our country. And so this is a really practical and a really, really good, important question. A couple of the folks at our accelerator meeting that we had actually run companies focused around out-of-pocket cost billing and will help us to understand what some of that market looks like. And I think to give you the honest answer is that it's kind of like the business case for primary care. You don't always have a business case for some of the preventative care in a short-term timeline. It doesn't mean that it's not the right thing to do. And so there's a certain combination with what is right, with what is already set up in financial incentives. There are pockets, though, that currently exist. For example, I came from Los Angeles. There's a lot of competition around certain services. Patients, employers, they can do business with different healthcare providers, different practices, different medical centers. So one of our contacts actually does transplant surgeries for kidney and liver transplants. And they are able to provide that service of higher quality with less complication for very, very sick patients at a lower cost than the big academic centers in the region. And a lot of business is leaving the big academic centers because it's too expensive. Employers, similarly, when they provide insurance to their employees, want to sign a contract where their employees are happy so they come back to work. And that includes both not only the quality of care, but also the cost that they're helping to fund, right, for their employees. So employer-based contracts, the competition in the market, I think, are there. And then the last thing is the policies around the corner. The Surprise Billing Act is just the beginning. There's going to be more to follow it because the public is asking for it. The voting public is asking for it.
I'd love to ask Jennifer to weigh in on that question of, how to build a business case for financial navigators, if she has any thoughts about that.
I don't know if I have good feedback about that, but I was actually going to put in the chat about how to approach these conversations, the financial conversations with families. We actually have a social worker on our team, Devin Traxler, who wrote a really great blog post. It's called How to Approach Cancer Care, How to Approach Cost Conversations with Families. And I can put the link in the chat, but I think it really talks about really great tips on how to approach those conversations.
Jump forward to the next slide about rebuilding trust. And I think we actually just started covering naturally some of this, but I wanted to go to the next slide and actually share a resource, I guess, with you all, which is an article actually in JAMA that we had written called Rebuilding Trust in Relationships in Medical Centers that focus on healthcare affordability. And this was along with Leah Binder and also our Executive Director for Cost of Care, Chris Moritas. So if we jump to the next slide, we hit on some of the key components or lessons learned from that article. some of which we've discussed. One being really thinking thoughtfully about partnering with patients to improve strategies, workflows, and tools. And I think this is one of the things where we often give lip service to, but there's few organizations that are truly doing it. But as we've seen, bringing the patient story that's walked through the ins and outs of where the bills happen, where the friction points are in their experience is so enlightening to build a program that's actually going to move the needle on this. And I think for systems and practices that really invest in building that infrastructure to find a structure to bring patients into those conversations, it is such an important thing to kind of focus strategy around. The second thing is having a more focused approach on reducing patient out-of-pocket costs and doing it with real meaningful outcomes. And again, this sometimes practically can be limited by the data that's available. But I think some of those examples, like University of Utah, that said, we're going to pick the top 20 that are outpatient, 20 that are inpatient, or the top X number of medications, the platforms that we have with transparency around medications, can provide those out-of-pocket costs to have real-time point-of-care discussions around them and making sure that we are focusing on those targets specific for patient out-of-pocket costs and not just total cost of care. The third component here is that communication. And I don't think I can say it better than Renee did with the example from her story. And I think many of us as patients ourselves or within our families have stories like that. But being able to communicate in the moment when questions arise, in advance when we know that there may be expected care that we can counsel patients around. And I think from a health system too, being able to communicate to patients or even communities that this is an important priority at this medical center. That is something that we're working on and that we see and are noticing. And I think that's very different than what most centers are doing that could really create attention in a different way. So I'm going to open that up also to back to Renee about, how could you envision partnering or what patients could do to partner? And I think it would be great, Renee, to hear a little bit. We have been focusing a lot of the conversation on health systems because we have some managers on the call that work within health systems, but also that connection with Family Reach that you've had, which is a group that cross-cuts all of the different providers that you have, and follows you. So any ideas that you have about either of those would be great to hear.
Well, I definitely think that having patient involvement is always going to be a strong point in the healthcare system, period. It gives other patients hope. It restores everybody's faith, and it does rebuild that trust when you see positive outcomes from something that is so critical and crucial to many, many, many people. And it opens that empathetic door as well, because you feel cared for. My need for reaching out to Family Reach inspired something in me that I didn't see coming. I was a preschool teacher before my metastatic cancer, and I was perfectly fine with that career. I love teaching preschool. But then throughout all of that, when I did end up needing help and I did financially become overwhelmed and I found Family Reach, I just felt this call to be involved and to share what is available for people like me in this situation, and then start to understand, why are there so many people in this situation? Why are there so many? If 1 in 8 women is diagnosed with breast cancer, why is it so unobtainable to get the care that you need? It just boggles my mind. So like I said, I think that the best way that we can improve the system is to have power in the system by incorporating patients and getting us to talk and to share about these things, because nobody's going, like I taught my preschoolers, you have to speak up so that we know what you're saying, we know what you need. And if nobody talks about any of this, then it's never going to get fixed.
Thank you so much to Renee. every opportunity we have to engage you in this work is just like, it's so necessary. It's so uplifting for us to be around everybody, knowing we're all trying to make this better for all of us. And so thank you for joining, Jennifer. Thank you for joining Kelly and your team and the ABIM Foundation. Thanks for having us today. And we wanted to thank everyone for engaging with us. And if you're interested in cost of care resources, I'm just going to go quickly through some of them. They're all free except for the textbook at the end. First, I'll just let Jennifer touch again on the important financial treatment program from Family Reach.
Yeah, thank you, September. And Reshma, you talked about the importance of having conversations with families, about the cost, not only the direct cost, but the indirect cost, such as parking and transportation and childcare. And typically those conversations are done by a social worker, having those conversations with families, but we're really trying to branch out and empower other healthcare professionals to have these conversations with families because they might be seeing them earlier in their cancer journey. So with that, we have the financial treatment program, which I mentioned, that includes the financial education, financial coaching, resource navigation, and emergency relief funds. The financial education, we have a guidebook to cancer, which is a tool that's downloadable on our website. And it really helps engage healthcare professionals with families to talk about finances. So it's a really great tool that's downloadable on our website. There's 3 different versions for different age populations, so you can check that out at familyreach.org there. Our financial coaching is another pillar of our financial treatment program, and the program connects patients and caregivers with financial coaches who are certified financial planners. And it's a free service that provides this guidance to families navigating their finances during cancer treatment. And resource navigation is another pillar. So we have social workers on our team that really work with families collaboratively to assist them in really aligning the most meaningful resources with families surrounding their financial circumstances. And then finally, our emergency relief funds, that's eligible for families that are eligible for that piece. It includes household expenses like rent, mortgage, utilities, food, transportation, and more. So that's our financial treatment program. Again, you can check it out on our website at familyreach.org. And I'll hand things back over to you, September.
Before I get into the cost of care, Daniel, did you want to ask something?
I just wanted to reflect on Renee's stories, not story, her life, and the difficulty she's had, and what you've done to share this story with us. We are deeply appreciative. But I think it points out something that in the Choosing Wisely campaign and in the Cost of Care campaign, I think has corrected it, is that we really need to focus on care that has value and the care that does not have value. And if we don't do both, we lose the trust of the public and patients. We have to be two-sided about this. I frankly resisted this for many years, as Reshma knows, because I did want to emphasize all the things that are not valuable so we can afford what is valuable. But Renee really points that out, and it's particularly true in underserved populations and historically marginalized populations. And I think Renee is saying, I just want the care I need. Don Berwick used to say, give me all the care I need, no more, no less. And so I want to bring that out, that message really in your talking really brought that out. So thank you again. I really admire your courage.
Thank you. Thank you, Daniel. Next slide. I'll go through these really quick. Our main site, costofcare.org. Next. our affordability moonshot, moonshot.costofcare.org. You can go on, fill out a thought bubble of the type of world you envision in healthcare. Next, you can follow us on Twitter at Cost of Care. Next, we launched a new program called Stars Unite, supported by the ABM Foundation and the Macy's Foundation, focused on providing leadership coaching and training to interprofessional teams that are really focused on value and equity, improving care for patients in the communities that they're serving. Next, our Innovate podcasts, 20 minutes long, innovations in value, affordability, trust, and equity. And our latest one is Daniel Wolfson, the one and only, talking to our founder and chairperson of the board, Dr. Neil Shaw, discussing the Building Trust Initiative. Next, we've collected so many stories from patients and clinicians on the front lines of care. A great place to go to hear real stories that highlight the real impacts of care. Next, multiple frameworks. We have our cost framework, which we originally created when we were really deep into the value-based healthcare space. And then, our more recent that we've talked about, our affordability framework, helping health systems focus on ways to improve affordability. Next, we've created free modules that introduce you to the concepts of value conversations and how to have better cost conversations with patients, colleagues, and supervisors. And then our executive director, Chris Moriades, is assistant dean for healthcare value at Del Med, created an incredibly valuable, comprehensive value-based healthcare module series, and that's totally free. Next, Dr. Moriades and Dr. Gupta created the high value care culture survey. So you can survey your organization to figure out where you guys sit in value culture. Next, some of our partners who are doing great work. As always, the ABM Foundation supports all that we do, and Choosing Wisely, the Leapfrog Group, and then the High Value Practice Academic Alliance, based out of Johns Hopkins, where they're really engaging change agents all over the country who are improving value-based healthcare. And then last, like I said, not free, but I did want to touch on it, textbook, Affordable, a practical guide to really understanding value-based healthcare, and each chapter is grounded in a real patient or clinician story that we collected, and it really helps guide the front lines of healthcare on how to truly make an impact in better delivery of healthcare.